Hello everyone. Welcome to another Case of the Month presentation where I'm going to present to you a allograft renal biopsy. This is from a 48-year-old male patient. The patient had end-stage kidney disease due to focal segmental glomerulosclerosis. There's no family history of FSGS, and the patient was transplanted only 2 months ago. Pre-transplant, what the clinicians inform us is that the proteinuria was 12.5 grams per day. After transplant, it fell to a minimum low of 6.2 grams per day, whereupon it started increasing, and at two months post-transplant, it had increased again to 8.5 grams per day, in which case they biopsied the patient. And here's what we see in the biopsy sample. You can see here the glomeruli, the tubules. There's not a lot of inflammation in this area. When we move on, I'll zoom in. In this glomerulus, what we can see is like the podocytes, they're really hypertrophied. You can easily make out their cytoplasm. And even this area, you start wondering about whether the capillary tuft is segmentally obliterated or not. And this is another glomerulus. This one looks fine. As I said, there's not much inflammation. There's only focal inflammation. And this inflammation seems to be located in areas where we have glomerular pathology. You can see this glomerulus again. The special stains are going to highlight all the stuff that I'm going to be talking about. But what draws again our attention is that the parietal epithelial cells, they look activated and hypertrophied a bit. And in fact, there's a little area of adhesion here, where the capillary tuft has adhered to the Bowman capsule. And again, this segment looks like there's a bit of obliteration. Again, this one, we have to keep an eye on this glomerulus as well. As I said, there's a focal inflammation. There wasn't predominant or substantial peritubular capillaritis. And this inflammation is usually located in areas where we've got glomerular pathology. Okay, let's move on. Let's zoom into this glomerulus as well. We're concentrating on the glomeruli since our primary problem is proteinuria. There, I've zoomed into this one. This is the hilus. And the perihilar area, again, you've got this area where there's increase in matrix, maybe hyalinization. There's this red dot here. Again, the podocytes are quite easily seen. They look like they've hypertrophied, as well as the parietal epithelial cells, which also look a bit more plump than usual. Another glomerulus where we can see the hilus, and we're going to keep an eye on this glomerulus as well, where we've again, as you can see, started seeing some inflammation. There's an artery here, biopsied along its length, and you can see that the intima is quite thick, which is probably due to hypertensive changes in the donor. Now, when we look at the trichrome stain, intimal fibrosis, as we said, it's much easier to appreciate it here. The intima is really thick with fibrosis. Let's zoom in. I can again see some parietal epithelial cell hypertrophy over here, and I'm going to move on. See this glomerulus, we can actually now appreciate that there is an area of segmental sclerosis. There's even hyalinization at the point of adhesion to the Bowman capsule. The parietal epithelial cells are hypertrophied as well as the podocytes here. Another glomerulus where we can see that the parietal epithelial cells may be in serial sectioning. This one is also going to have an area of adhesion. Again, this one, like the segmental area, might have a bit of capillary tuft obliteration in that area. As you can see, there's no considerable inflammation or peritubulary capillaritis. Now this is the silver stain, which again shows the intimal fibrosis, and which again highlights beautifully, in fact, highlights that area of segmental sclerosis with the hypertrophied podocytes, hypertrophied parietal epithelial cells, an area of adhesion as well as increased matrix production. Sclerosis. Let's move on. This glomerulus, we can't really appreciate it that good, but it's at the very edge of the biopsy. This is also probably an area of segmental sclerosis. It really looks like it. This one again, probably there's going to be an area of segmental sclerosis here. You can see that the parietal epithelial cells have hypertrophied. If I pick up the pace, this is the second core. Where again we've got a little bit of inflammation. That does not make up 10% of the total cortical parenchyma. And as we move along, again, we come across this glomerulus where the capillary tuft is obliterated. There's increase in matrix production in the perihilar area, which is beautifully highlighted with the silver stain. Which I am going to show you here. As you can see over here, you can see the adhesion, you can see the obliterated segment. As you know, focal segmental glomerulosclerosis can have diverse pathogenic mechanisms. This one back on. One of which is the presence of the so-called circulating permeability factor, which might actually be a cytokine, and it is the most common cause of early recurrence in transplant cases, which is how this patient was diagnosed, recurrent focal segmental glomerulosclerosis. It was, as you can remember, only 2 months post-transplant this patient was. And in fact, up to 30 to 40% of patients with transplants do have recurrence of, who have idiopathic focal segmental sclerosis in the native kidney, do have recurrences post-transplant. And in fact, if you take these kidneys out and retransplant them to patients without idiopathic focal segmental sclerosis, you can see remission of the podocytopathy, and the kidney can function very well, and there won't be any, the proteinuria will regress, which is again supportive of this hypothesis of a so-called circulating permeability factor. The fact that there's no family history is also important here, because in those patients with family history, you usually think about causes such as heritable mutations of podocytes, which do not tend to recur in after transplantation. And this patient, we know, did not have any family history and had recurrent focal segmental sclerosis, as you can see in this biopsy, and hence was probably had idiopathic focal segmental glomerulosclerosis to start off with. Well, thank you very much. Hope you enjoyed this case.